Okay, let's unpack this. Today, we're diving into a topic that's not just crucial for orthopedic surgeons, but especially vital for anyone navigating their postgraduate exams like the FRCS or similar fellowships. We're talking hip resurfacing and metal on metal, or MOM. HIP's a subject that's been on a fascinating and, well, sometimes challenging journey. All the insights we're exploring today are drawn from the incredibly thorough Ortho Made Simple notes, which you can find on mokyingren.sg. These notes are thoughtfully compiled by Dr. Mok Ying Ren, who's a sports surgeon over at National University Hospital, Singapore. He actually got his FRCS back in 2022. So we're getting information from someone who has truly walked this path.
Absolutely. And what's truly fascinating about this area, I think, is how much it embodies the iterative nature of medicine. You have this promising innovation, then some unexpected challenges pop up, and that leads us to a deeper, more nuanced understanding. Our mission today really is to take you through that full arc, from the early perceived advantages that made MOM resurfacing so appealing, to the significant complications that emerge, and crucially, how we've learned to manage these complex issues. We want to equip you with the essential knowledge to confidently approach this topic, both in theory for your exams and, in the practical realities of your future practice.
It's a great framing. So let's cast our minds back then to the early days. What made metal-on-metal hip resurfacing such an exciting prospect? What were those big selling points that really grabbed the orthopedic world's attention?
Well, there were primarily four key advantages that made it seem so attractive at the time. First, and perhaps the most intuitive one, was the large femoral head size. You see, unlike traditional total hip replacement, resurfacing essentially caps the existing femoral head, right? This allows for a much larger diameter bearing.
Okay.
And that translates directly to a higher head-neck ratio, which significantly increases the physiological range of motion and drastically reduces the risk of impingement. And crucially for patients, it also means a larger jump distance.
Jump distance?
Yeah, that's the amount of displacement needed before the hip actually dislocates. So it makes dislocations far less likely.
Okay. So better movement, less dislocation. Two major wins, especially for active patients, right?
Exactly.
What else was on that list?
Second, the unique lubrication properties of metal on metal. These surfaces, they have this remarkable ability to sort of self-polish during an initial run-in phase. But beyond that, there's a phenomenon called hydrodynamic lubrication.
Hydrodynamic lubrication.
Yeah, it basically creates a fluid film between the bearing surfaces, almost like a thin layer of oil, and that dramatically reduces friction. This was seen as a significant theoretical advantage. Third, and this was a huge draw for younger patients, was its bone-preserving nature.
Right, you're not removing as much bone.
Precisely. Compared to a traditional THR, where a significant portion of the femoral head neck is resected, resurfacing removes considerably less bone. People saw this as a way to maybe buy time or, leave more options open for future revisions if they were needed down the line.
That makes perfect sense, yeah. Especially for younger, active people who want to maintain their lifestyle and maybe face a longer implant lifespan. And the fourth advantage?
Finally, it was the improved wear characteristics, or so it was thought. When you compared it to polyethylene, the wear particles generated by MEMOV implants are much, much smaller. The initial belief was this would reduce osteolysis, the bone destruction caused by wear debris. Furthermore, the total wear volume was significantly less. We're talking maybe 1 to 6 micrometers per year for MOM versus 0 to 200 micrometers often seen with polyethylene. So you put it all together, better mechanics, theoretically less wear, preserving bone. It really seemed like a revolutionary step forward at the time.
It really does sound like a fantastic leap on paper, but as often happens with these kinds of innovations, doesn't it? The initial excitement soon gave way to a more sobering reality. The very advantages that made MOM hips appealing started to reveal a darker, more complex side. Specifically, this spectrum of conditions we now understand as adverse reactions to metal debris, or ARMD.
Absolutely. This is where the story really takes a turn. The disadvantages, they primarily manifest as both local and potentially some systemic concerns as well. Locally, ARMD isn't really a single condition. It's more like a spectrum of 4 distinct issues. First, there's metallosis. That's essentially the metal staining of local tissues causing that characteristic black discoloration you might see. Second, we see pseudotumor formation.
Pseudotumor sounds ominous.
It does, but it's important to understand what it is. It's a granulomatous lesion, basically an organized collection of inflammatory cells that develops near the hip replacement. It can actually look like a tumor on imaging, which is why it gets the name.
Wow.
But it's crucial to remember it's neither infective nor cancerous.
Okay, so the body's creating this sort of inflammatory mass in response to the metal.
Yeah.
Got it. What are the other two aspects of this reaction?
Third, we have alveole. That stands for aseptic lymphocyte-dominated vasculitis-associated lesion. Now, this is really a diagnosis we make under the microscope, a histological diagnosis. It indicates a very specific inflammatory response at the tissue level, characterized by, well, lots of lymphocytes, and it affects blood vessels. You can think of alveole as the body's sort of super specific, almost allergic cellular level reaction against the metal. It's what we look for to really understand the biology.
Okay, alveole.
And fourth, there's macrophage-induced osteolysis. This is direct bone destruction, and it seems to be caused by a type 4 hypersensitivity reaction to those tiny metal particles. It's essentially the immune system attacking the bone because the metal's there.
Wow. So basically our bodies sometimes treat these high-tech implants like alien invaders causing all sorts of local drama. And you mentioned systemic concerns too.
Yes, on the systemic side, there's been concern about increased metal ions, specifically cobalt and chromium leaching into the bloodstream. There's been discussion about whether these elevated levels may be carcinogenic or perhaps teratogenic, meaning potentially harmful to fetal development. However, and this is important to stress, while the concern exists, current evidence does not definitively confirm a causal link. We need to be clear about that.
Right, so a potential concern but not proven. Okay. Given all these different reactions, it's natural to wonder, what exactly is triggering ARMD? Is it simply the metal itself, or is there more to the story? What actually causes it, and what puts certain patients at higher risk?
That's a crucial question, and the answer is, well, it's almost certainly multifactorial. We really can't point to a single cause. Several studies clearly link ARMD to increased wear. And this wear can be exacerbated by issues like implant positioning, maybe suboptimal positioning, and something called edge loading.
Edge loading.
Yeah, that's where the femoral head articulates right at the very edge, the rim of the acetabular component, instead of being well seated within it. That generates a lot more wear particles.
Yeah.
However, what's fascinating and adds complexity is that we also see pseudotumors appearing even when wear features seem minimal. This strongly suggests that hypersensitivity, an immune response specific to that individual patient, plays a significant role too.
Ah, okay.
And it's also worth noting pseudotumor reactions have actually been reported even with non-mammalian bearings sometimes, which further supports the idea that the body's specific immune reaction is a key component, not just the metal type itself.
So it's not just about how much metal is wearing away, but also how the individual patient's body reacts to whatever is there. That makes sense. Are there specific patient characteristics or implant types that put people in a higher risk category for ARMD?
Absolutely. There are definitely clear factors we look out for. For STEM THR, a femoral head size greater than 36 millimeter is a known risk factor for ARM bearings. But for hip resurfacing, the risk profile is different. Generally, all females are considered higher risk for resurfacing ARMD. All Dupuy ASR hip implants, those are explicitly high risk. And hip resurfacing implants with a head size less than 48 millimeter are also in this higher risk category.
Okay.
And then from a technical perspective, an acetabular inclination greater than 55 degrees is also a significant risk factor because it really promotes that edge loading we talked about.
Wait, hang on. That's a really interesting point and something that could easily trip someone up in an exam, right? You just said for resurfacing, a smaller head size, less than 48 millimeters, is a risk. But for stemmed THR with MOM, a larger head size, greater than 36 millimeter, is a risk. That sounds contradictory on the surface. How do we reconcile that?
That's a fantastic observation, and it really highlights a critical nuance you absolutely need to grasp for your exams and practice. This apparent dichotomy isn't just some, anatomical detail. It actually underscores a fundamental shift in understanding wear, moving from just size to complex biomechanical interaction. It's a lesson learned the hard way. So for hip resurfacing, a head size less than 48 millimeter increases the likelihood of impingement and edge loading. Imagine maybe 2 billiard balls. The smaller one has less leeway within the socket before it jams or rubs on the rim, right? Leading to concentrated localized wear.
Okay, I see. Smaller head, less room for error in the socket.
Exactly. In contrast, for a STEM THR with a MUM bearing, a femoral head size greater than 36 millimeter leads to increased frictional torque, just more surface area rubbing, basically, and consequently greater volumetric wear overall. The mechanics are fundamentally different between the two implant types, so while both scenarios elevate risk, the underlying biomechanical reasons and the mechanisms of wear are quite distinct because of the different designs and how they function.
That's such a crucial distinction. It really highlights how context-dependent these risk factors are. That's gold for residents studying this. So let's pivot now to the clinical trenches, as it were. You've got a patient presenting with a painful MILM hip. What's the very first thing you're running through in your mind, even before investigations? What's your systematic approach?
You're absolutely right to frame it clinically. The first thing, and you absolutely must do this, is rule out infection. Infection can mimic so many symptoms of ARMD, and missing it can have truly catastrophic consequences for the patient.
Okay, infection first, always.
Always. Secondly, rule out extrinsic sources of pain. Sometimes the pain isn't from the hip at all. It could be referred from the spine or other structures nearby. Once you've addressed those possibilities, your evaluation and follow-up should really be based on established guidelines. Here in the UK, we often refer to the MHRA, that's the Medicines and Healthcare Products Regulatory Agency. They set a high standard for how we monitor these cases.
Right, rely on those robust guidelines. And how did those guidelines shape your actual ARMD screening protocol? Does it vary depending on the patient's risk profile?
Precisely. The follow-up frequency is definitely risk stratified. For the high-risk groups, that's whether they're symptomatic or not, and also for low-risk patients who are symptomatic, yearly follow-up is essential. This includes assessing their Oxford hip score, doing a detailed clinical symptom review, and crucially, getting annual measurements of their metal ion levels, specifically cobalt and chromium. Now, if their symptoms are progressing or if those metal ion levels are rising, then an MRI is definitely indicated.
Okay, yearly for high risk or symptomatic low risk. What about the others?
For the low-risk asymptomatic patients, the schedule is a bit less intensive, especially initially. It's typically annually for the first 5 years post-op, then every 2 years until year 10, and then every 3 years after that. Again, you'll monitor their Oxford hip score, clinical symptoms, and metal ion levels at each visit. X-rays are usually taken at each visit too. And if those show any abnormality, or if symptoms develop, or if the metal ion levels start to rise, then an MRI is indicated for them as well.
So it's this careful combination of clinical checks, blood tests, and imaging, with MRI being the key investigation if concerns arise. What are the definitive triggers then? When do you actually say, okay, this patient needs a revision surgery?
Critically, the indications for revision surgery typically involve having high metal levels. The threshold we generally use is greater than 7 parts per billion for both cobalt and chromium and abnormal findings on MRI imaging. It's usually not one or the other in isolation. It's the combination that pushes you towards revision. And when it comes to classifying those MRI findings, specifically in metallic hips, we use the Anderson classification.
Anderson classification, right?
Yes, it gives us a standardized way to describe the extent of the disease we're seeing on the scan. It categorizes findings from grade A, which is essentially normal appearances, although this can include simple fluid collections or seromas. Grade B indicates infection. Then grade C1 is for mild MOM disease, usually defined as a soft tissue mass less than 5 centimeters. C2 is moderate MOM disease, so a mass greater than 5 centimeters, maybe with some muscle atrophy. And grade C3 represents severe MOM disease. This includes really worrying findings like fracture, tendon avulsion, or significant bone marrow signal change. So essentially, it gives us a clear roadmap, doesn't it? From a normal-looking hip scan to a full-blown crisis needing urgent attention. It's like a severity grade for the body's reaction.
That's incredibly helpful for standardizing assessment and communication. Now, within that context, one specific aspect of ARMD, the pseudotumor, often raises questions. If you find a pseudotumor on imaging, what's the single most crucial diagnostic insight for a resident here? Is it just about early detection, or is it understanding that not all pseudotumors are created equal? I mean, do you need to rush in and excise every single pseudotumor you find? It sounds like a complex decision.
You've hit on a point of significant controversy and ongoing discussion, actually. The crucial insight is definitely that not all pseudotumors are created equal, and not all require immediate surgery. Well, the MHRA guidelines suggest considering revision if there's an abnormal MRI and or raised metal levels. Our understanding of the clinical relevance and the natural course of these silent or asymptomatic pseudotumors is still quite limited. We're still learning. Furthermore, revision surgery itself in this context can have poor outcomes sometimes. It's often complicated by incomplete excision of the pseudotumor tissue or recurrence, sometimes even needing further reoperations.
So surgery isn't always this straightforward answer.
Not at all. There was a notable study by Walter and colleagues published in the Journal of Arthroplasty back in 2013. They looked at 248 patients with MOM hips and found a pseudotumor prevalence of 36%. That's quite high. However, only 5 patients in their cohort actually required revision surgery. And those patients were both symptomatic and had elevated metal ions.
Wow, that's a powerful statistic. 36% had one, but only a tiny fraction the symptomatic ones with high ions, needed surgery. So what was Walter's recommendation based on that finding?
Well, based on their findings, Walter et al. Recommended revision, primarily in cases of that severe grade C3 disease we talked about and metal ion levels greater than 7 ppb. They also suggested considering MRI follow-up, perhaps every 6 months, for less severe or asymptomatic lesions until you can confirm the lesion's stability, that it's not growing or changing rapidly. So it really emphasizes more of a watchful, waiting approach for many of these cases, rather than immediate intervention. Intraoperatively, though, if you are revising one of these MEM hips, you should definitely prepare yourself. You'll often find what's described as dishwater fluid, a sort of hazy gray appearance to the joint fluid, along with telltale black metal deposits staining the tissues and extensive synovitis, inflammation of the joint lining throughout the joint. It's a very distinct and often concerning picture when you see it.
It sounds like managing these patients is almost as much detective work as it is surgery, keeping an eye on things, looking for those key triggers. And when revision is indicated, you've mentioned it's a complex procedure. What makes these revisions so much more challenging than, say, a standard primary THR revision? What are the key considerations and steps for such a demanding surgery?
It truly is a heightened level of challenge, yes. The core difficulty really lies in the potentially significant soft tissue damage and bone destruction that RMD can cause over time. It's not just a matter of swapping out parts like in some revisions. You're often dealing with a really compromised biological environment. We often use the ergonomic to guide our strategy for these complex revisions. It helps keep things systematic.
ERRs. Okay, what does that stand for?
It stands for enlist help, get experienced colleagues involved. Don't tackle these alone. Ensure adequate exposure. You often need a wider view than usual. Extract the components carefully, as they can be quite ingrown or surrounded by reactive tissue. Evaluate the damage and debride aggressively. This is key. Removing all involved, stained, and damaged tissue. Then reconstruct the deficient bone and soft tissues as needed. Replace the components with your chosen revision implants. And finally, focus intensely on rehabilitation postoperatively.
That aggressive debridement and reconstruction must be particularly challenging, especially given the tissue damage you mentioned. What about the preoperative planning specifics?
Yeah, the debridement is critical. Preoperatively, it's absolutely vital to thoroughly evaluate the extent of the pseudotumor's destructive effects. We rely heavily on MRI and often CT scans as well to precisely assess the remaining bone stock. These pseudotumors can cause really extensive paraprosthetic bone loss and soft tissue destruction. So you might need to consider using advanced implant options like dual mobility cups or even constrained liners if the destruction is severe, just to improve post-op stability. Templating for bone loss is paramount. You need to plan for it. And you may well need long revision stems to bypass any defects or provide solid distal fixation in compromised bone.
Right, planning for the worst case scenario with bone loss.
Exactly. Intraoperatively, as I mentioned, extensile exposure is typically required. And then that aggressive, meticulous debridement of all involved tissue. You really want to ensure no metal-laden or obviously inflammatory tissue remains behind. Postoperatively, a strong focus on rehabilitation is essential for patient recovery, often involving modified weight-bearing protocols or maybe some range of motion restrictions initially, depending on the reconstruction.
This whole journey of MEM hips really highlights that iterative nature of medicine, doesn't it? A promising innovation, then unexpected challenges, leading eventually to a deeper understanding. And speaking of deep understanding, just a reminder that we're drawing all these crucial insights from the exceptional Ortho Made Simple notes, which you can find over on mokyingren.sg. Let's now pivot slightly. Despite all these serious potential complications we've just detailed, why does hip resurfacing still hold a specific, albeit quite narrow, place in our surgical toolkit today?
Yeah, it really begs the question, doesn't it? Given everything we've discussed, why is hip resurfacing still performed at all? And perhaps more importantly, for whom is it considered an appropriate procedure nowadays? What keeps it on the table, even as an option?
Well, despite all the challenges and the high-profile issues, hip resurfacing still holds certain perceived advantages, but primarily for a very specific patient profile now. Things like potentially a better restoration of the hip's natural biomechanics. This might lead to enhanced proprioception, a more natural, almost intuitive feel for the patient's own hip position. There's also still the perceived benefit of improved wear characteristics compared to polyethylene, specifically avoiding polyethylene-induced osteolysis. And that larger hit size we talked about right at the start, that still means theoretically a greater range of motion and a reduced dislocation risk compared to some smaller-headed THR options. And crucially, perhaps the biggest remaining argument, is the improved femoral bone stock preservation.
leaving more bone for the future.
Exactly. That's a significant potential advantage if a future revision surgery is ever needed down the track, as it leaves more of the patient's natural bone intact to work with. So for these reasons, the ideal patient for hip resurfacing is now quite narrowly defined. It's typically considered for young, very active males, often those who remain heavily involved in impact sports or strenuous manual labor.
So it's really about picking the right patient extremely carefully. Selectivity is key. For a resident listening, understanding precisely when to recommend this, or perhaps more often when to avoid this procedure, is absolutely critical, not just for exams, but for safe future practice. What are the clear indications, which sound quite limited now, and perhaps more significantly, that extensive list of contraindications?
Absolutely. Patient selection is paramount. The indications for hip resurfacing are now, as you say, quite restricted. A vascular necrosis, AVN, of the femoral head is generally considered a good indication, but only provided there is sufficient healthy bone stock remaining in the femoral head to support the implant. However, the list of contraindications is far more extensive, and these are absolutely vital to remember for exams and practice. We can categorize them by patient factors, anatomical considerations, specific pathologies, and even surgeon factors.
Okay, can you break those down for us, starting with the patient factors?
Sure. For patient factors, clear contraindications include severe osteoporosis, obviously, any female of childbearing age, primarily due to those systemic metal ion concerns we discussed earlier. Severe obesity is generally a contraindication. A known or suspected metal allergy. Significant kidney disease, as that can affect metal ion excretion and bone metabolism. Or current long-term steroid use, basically any condition that predisposes the patient to poor bone quality or osteoporosis, makes resurfacing much riskier.
Right, anything that weakens the bone is a red flag. What about anatomical reasons?
From an anatomical standpoint, things like large cysts within the femoral neck would be a contraindication as they compromise the bone supporting the implant. A very narrow femoral neck might also be considered too high risk for fracture. Females often have smaller femoral heads anatomically, and some surgeons consider a head size less than, say, 46 millimeters an absolute contraindication due to the technical difficulty and potentially higher wear rates. Hip dysplasia is also generally a contraindication.
Okay, and specific pathologies.
Regarding pathology, while AVN can be an indication, other conditions like DDH, developmental dysplasia of the hip, and Perthes disease are generally considered contraindications for resurfacing. And finally, and this is crucial, surgeon inexperience is a very real contraindication.
Ah, the surgeon factor.
Yes. Hip resurfacing procedures are technically demanding, and they're becoming rarer. They really should only be performed by specialized high-volume hip surgeons who do them regularly. And even then, the decision should ideally be discussed with experienced hip colleagues to reach a consensus, ensuring it's truly the best and safest option for that specific patient.
It sounds like a real minefield of potential issues if it's not approached with the absolute utmost caution and expertise. So finally, beyond the ARMD issues, which we've covered in detail, what are the other specific complications and unique risk factors for failure that we need to be aware of when it comes to hip resurfacing itself?
Yes, beyond the metal-on-metal specific problems, the main unique mechanical complication associated with resurfacing is a femoral neck fracture. This occurs in roughly maybe up to 4% of cases in some series. These fractures are often linked to technical issues, like varus malpositioning of the femoral component during surgery, which places undue stress on the remaining femoral neck. Aseptic loosening of either the femoral or acetabular component without infection is another potential mode of failure, similar to THR. When we look specifically at risk factors for failure of hip resurfacing, they typically fall into three main categories again. Patient factors include having pre-existing poor bone stock, like we discussed, or significant comorbidities such as renal failure, which can lead to osteopenia or osteoporosis, affecting bone quality and the implant's ability to integrate.
Okay, so patient bone quality is paramount. What about the surgical or technical side?
Absolutely critical. Technical factors play a huge role. A high acetabular inclination angle, specifically positioning the cups deeper than about 40 or 45 degrees, significantly increases the wear rates and risk of edge loading, leading to more metal debris and potential ARMD. Also, inadvertent notching of the femoral neck during the surgical preparation can create a stress riser, weakening the bone and predisposing it to fracture later on. And finally, there are implant factors. Specific implant designs, most notoriously the DePuy ASR hip implants, showed significantly higher failure rates, which ultimately led to their global recall. Whereas other designs, like the Birmingham hip resurfacing, BHR, are generally considered more acceptable and have much better long-term data supporting their use in appropriately selected patients.
What a truly comprehensive deep dive into hip resurfacing and metal-on-metal hips. I think you've gained an incredible amount of insight today, really, from understanding that initial biomechanical appeal and the perceived benefits, right through to the critical nuances of adverse reactions to metal debris, its systematic management, and those crucial indications, and maybe more importantly, contraindications that must guide our decision-making. This knowledge, it's really not just about acing your exams, is it? It's about equipping you to make informed, safe, and ethical decisions for your future patients, ensuring you can anticipate challenges and navigate these complex scenarios with real confidence.
Absolutely. And if we try and connect this to the bigger picture, perhaps the whole journey of hip resurfacing serves as a potent reminder, doesn't it? It reminds us that even with what seem like major advancements, a critical eye and a long-term perspective are always absolutely essential in orthopedics. We need to look beyond the initial hype. It really raises an important question for all of us, I think. What other areas in our current practice might be seen as groundbreaking today, but could perhaps benefit from a similar, honest reevaluation based on evolving long-term data and patient outcomes over decades, not just a few years? Food for thought.
Definitely food for thought. And remember, all the invaluable insights we've shared in this deep dive today were made possible by those comprehensive Ortho-Made Simple notes available over at mokyingren.sg. Keep exploring, keep learning, and definitely keep asking those crucial questions as you progress in your career.
And as you continue on your journey, whether you're preparing for exams right now or serving your patients day to day, perhaps remember this piece of wisdom. Whoever trusts in his riches will fall, but the righteous will flourish like a green leaf. That's from Proverbs 11:28. May you be diligent in your studies, principled and ethical in your practice, and may you flourish like that green leaf in all that you set out to do. God bless you on your path.